Hi everyone, in this video I'm going to talk about sickle cell disease. I have an MCQ from UWorld too. So, what is sickle cell disease? It is an autosomal recessive sickling disorder. What happens in it is basically there is a amino acid substitution, a single amino acid substitution on the position 6 of beta globin chains of hemoglobin. So, hemoglobin has two chains, alpha and beta. So, what happens is in the beta globin chains, there is a substitution of amino acid which misshapes the hemoglobin completely, and it makes the normal hemoglobin, which is hemoglobin A, which is the normal hemoglobin for adult, it changes it from HbA to HbS. So HbS is the variant which is associated with sickle cell disease. And what HbS does is it is a little bit of it is a little similar to HbA, but it is misshapen. It can carry oxygen pretty well, just like HbA, but when it's deoxygenated, when it just dumps its oxygen, it just deshapes and becomes a sickle. So its shape turns to be like a sickle, and that sickle shape, what happens is it leads to destruction of the red blood cells itself, and also just like this sickle shape, and also it causes occlusion in the vessels. So it also causes vasoocclusion. So in all of the vessels it causes occlusion and then leads to many problems in different organs, which we're going to read over here. The organs affected by vaso-occlusive crisis. So that's what happens because of the shape of the red blood cell. So, moving forward, we're going to talk about there's an increased incidence of HB hemoglobin S allele in the people who live in sub-Saharan Africa, Indian people, Middle Eastern or Mediterranean heritage, and this hemoglobin S allele is thought to be protective against malaria. Now, what happens is sickle cell disease occurs when an individual, as it is autosomal recessive, so it occurs as individual have two hemoglobin S genes. So, homozygous HbSS hemoglobin SS makes them to have a disease. But if it's not homozygous, if it is one hemoglobin S gene and another one is just a mutant beta globin gene, then it is heterozygous, and we call it as a compound heterozygote. And most common is hemoglobin S beta thel, and the other one is hemoglobin SC disease. So we're going to read about hemoglobin SC disease also moving forward, okay? And what's the pathophysiology? At low oxygen levels, what happens is the hemoglobin S, when it gets deoxygenated, deoxyhemoglobin S polymerizes, leading to rigid crystal-like rods. So just like I told you before, it whenever it loses the oxygen, it deshapes and gets into rigid crystal-like rods which distort the membranes. That's the shape is called as sickle. So this is sickling, and how much of sickling is going to happen, that depends on the percentage of hemoglobin S present in that person. And what aggravates sickling? So situations in which, like acidemia, in which hemoglobin has to lose oxygen. In such situations, it loses oxygen and then makes polymers. Situations like increased carbon dioxide, increased 2,3-DPG. This is the enzyme which helps the oxygen carrying capacity of the red blood cell. So as it increases, it decreases the oxygen affinity. So increased 2,3-DPG means there is decreased oxygen affinity, and that means that it's gonna lose oxygen pretty quickly. So increased 2,3-DPG, or any fever, or increased osmolality. And we're gonna read about some dehydration too. In dehydration also, sickling happens most, okay? And then it also happens in small vessels, because in small vessels there's more and more chances of the blood to give more time in perfusion. So in small vessels the oxygen is more, the red blood cells are dumping oxygen in the small vessels to perfuse the tissues. So over there the deoxygenation is happening, and that thus more polymerization is happening. So more and more polymerization happens over there. So these are some situations which aggravate sickling. And in this flow chart we can also see one thing, that if the partial pressure of oxygen is low, then the hemoglobin S deoxygenates. It's gonna, whenever whenever we have low oxygen in the surrounding, right? If we are going to high altitudes too, there's low oxygen in the surrounding, so blood needs to dump more and more oxygen in the tissues. So a decreased oxygen in the surrounding would ultimately lead to deoxygenation of hemoglobin S and increased acidemia or increase in carbon dioxide. That would lead to more and more deoxygenated hemoglobin S, and then hemoglobin S will polymerize. Those polymers will form and they'll distort RBCs, and then there will be formation of sickle cells, and they're going to occlude the vessels. They're going to increase the blood viscosity too. They not only just occlude the vessels, they just rupture themselves too. So RBCs also get ruptured, which is hemolysis, and that would lead to when they'll rupture, they lose all the hemoglobin in the bloodstream. So there it happens intravascular hemolysis. Blood viscosity also increases, then the blood flow eventually slows down, and then again that happens, that oxygen decreases because of this, because the oxygen is not being provided in all the tissues. So the cycle continues, and the distorted red blood cells are gonna occlude vessels, which is called impaction, and then they're also gonna cause infarction. So, what are the two main ways in which these sickle cells can cause injury? Fragile sickle cells hemolyze, so they just hemolyze. They cause red blood cell destruction. They just destroy themselves, and then they also occlude small vessels and cause hypoxia or ischemia, reperfusion injury. Okay, moving forward, talking about the clinical features. So now I'm gonna divide hemoglobin SS. Over here we have sickle cell disease hemoglobin SS, and over here we have sickle cell trait, in which it's not hemoglobin SS. It's compound heterozygote. It has hemoglobin A also, and it has hemoglobin S. So it is a compound heterozygote, right? So in this table, I'm gonna give you a quick look. So there's hemoglobin A, A2, hemoglobin F, hemoglobin S, and hemoglobin C. Normally we have hemoglobin A in adults, a little bit of A2, very very minimal of hemoglobin F, but we used to have that while they're fetus, and then a hemoglobin S is not there and hemoglobin C is not there. What happens in sickle cell anemia, which is the red one, hemoglobin A, there's like almost 0% hemoglobin A, and all of the hemoglobin is in the formation of hemoglobin S, because this is homozygous hemoglobin SS. So all of the hemoglobin is in hemoglobin S form. But then in the purple we see sickle cell trait hemoglobin AS. So in this position, it has a little bit of hemoglobin A also, and a little bit of hemoglobin S also. So in this we have almost, you could say, 60% hemoglobin A and 40% hemoglobin S, which we're going to read here in this table too. Hemoglobin AS, which is a sickle cell trait, in on hemoglobin electrophoresis, we can say that there is hemoglobin A fraction of 65% and hemoglobin S fraction of 35%. So that's what happens when there is sickle cell trait, which is a heterozygous compound. And then there is hemoglobin SC disease. As its name indicates, it would have hemoglobin S and hemoglobin C, and not any hemoglobin A. So sickle cell trait. First, we're gonna read about sickle cell trait. It is basically asymptomatic. People like this, they have 60% of hemoglobin A. They are usually asymptomatic. They lead a very healthy life, except that there are some situations in which there is extreme hypoxia, or they are in situation like infections, or they have high fever. They are going on high altitudes, in which there is a trigger, because even if they have 60% hemoglobin A, we still cannot forget that they have 40% hemoglobin S. So their polymerization could occur, right? So because there is some sickling too, because of the 40% hemoglobin S, that sickling happens in the renal medulla. This leads to they usually spend a very healthy life, but they still have some complications like painless hematuria, because the sickling is happening in the renal medulla. And then they have hypostenuria. Hypostenuria is the inability to concentrate urine, so their urine is a little bit diluted. They don't have very highly concentrated urine. That would lead to sorry, that will lead to symptoms like nocturia and polyuria. So they have hematuria, nocturia, polyuria. They also have sometimes they also have UTIs, because and the sickle cell trait, just remember that some there is association with renal, right? There is kidney association, so risk of renal medullary carcinoma also is there. In sickle cell trait, renal medullary carcinoma. So hematuria, nocturia, polyuria, UTIs, and on if we are going on very higher altitudes and there is very aggravation of the precipitation. This is a precipitating factor for sickling, right? So on higher altitudes, it can lead to splenic infarction. Then we have hemoglobin SS, which is a sickle cell disease SS. This is homozygous. This is complete hemoglobin, the sickle cell disease. What happens in it is chronic hemolytic anemia, because after the polymerization there would be hemolysis too, which would lead to anemia. Jaundice in the first year of life, retarded growth and development with or without skeletal changes, but there is retarded growth and development. And what happens is, in the childhood they have splenomegaly, and in adulthood they have splenic atrophy. So in the early stages there is splenomegaly. There's so much of RBC destruction going on, so spleen is getting enlarged because the spleen RBCs are destroyed in there. So gradually the size of spleen increases, but eventually there starts to happen splenic atrophy, because there's a mechanism which is called as splenic sequestration, which we're gonna read right here, because that would be an acute pain episode. What happens in this splenic sequestration is that in children, as the spleen size is increasing, the blood tends to pool inside the spleen, resulting in acute hemoglobin drop. So there's acute hemoglobin drop, and this leads to shock, right? But this sequestration doesn't happen in adults. It's very uncommon in adults, because there is asplenia, you could say. Yeah, because there's vaso-occlusion going on in all of the organs because of the hemoglobin S polymerization. So in spleen there happens, the spleen is being bigger and bigger in size, and then there's vaso-occlusion, and the spleen has not been perfused properly. So what happens is, eventually smaller, like little by little, spleen starts to getting infarct. Gets infarcted at one point of time, at one point, but then the next, and then the next, because of the vaso-occlusion. So these repeated infarction leads to what we can call as autosplenectomy. It starts to go into atrophy, and there is asplenia. So we did not remove the spleen, we did not did any splenectomy, we did not do any splenectomy, but there is no more spleen anymore. So this is functional asplenism. There's no organic cause behind it, but functionally there is no spleen is not working there. So this would increase the susceptibility to infection by encapsulated organs like strep throat and meningitis, Neisseria meningitis, H. influenza, salmonella, and salmonella can lead to osteomyelitis. So functional asplenism could lead to increased susceptibility to infections with these organisms. So now talking about hemoglobin SS, we were talking that in childhood it's splenomegaly, and in adulthood it's splenic atrophy because of the repeated infarction. So the sickle cell disease in the homozygous person, it can present with acute pain episodes, and pain episodes could be of various reasons. We have crisis going on, which can include aplastic crisis, because there is any toxins, any infections, especially parvovirus B19 infections. What do they do is transiently suppress the bone marrow, and then there is aplastic crisis, because as anemia, there is hemolytic anemia going on in sickle cell disease. We've read with the hemolytic anemia, the body tries to counteract the decrease in the hemoglobin, and then they have new they the bone marrow tends to increase the reticulocytes, right? Just to combat, just to compensate the decrease in the hemoglobin, which was because of the hemolytic anemia. So there is new bone formation, and then you can also see some expansion of medullary cavities in the skull. They present with enlarged cheeks, and then on skull, the X-ray of skull, we can see hair on and appearance. So this is how they are trying to compensate the decrease in hemoglobin, and that this is the reason we find increased reticulocytes in hemoglobin SS. Okay, so but when there's any infections, there's any toxins going on, they're going to suppress bone marrow, right? But that is transiently, which is what we call as aplastic crisis. But there is pain crisis in bones also, because of the avascular necrosis, because of the vaso-occlusion. All of these crises are more or less because of the vaso-occlusive crisis. So because of the vaso-occlusion, there is avascular necrosis in the bones, and then they do have some pain. They usually have pains in their like bones, we could say their extremities, like arms, and their legs. And then there is also a term called as dactylitis, which is inflammation in the digits. There is pain and inflammation in the digits because of the vaso-occlusion. Okay, so the splenic sequestration crisis we already read, because of the pooling of blood in the spleen, and decreased hemoglobin in the body. Rest of the body, there's a hemoglobin drop, and then the child goes into shock. But it is not that common in adults because the spleen is already atrophic. Vaso-occlusive crisis, infarction, many organs are affected. Ischemic reperfusion injury, especially in the back, chest, we could say abdomen and extremities. Just like I mentioned already, they have pain in extremities in their abdomen, and they present with fever and leukocytosis. It can also cause a stroke or a silent MI. And how is this precipitated? Just like we talked about the sickling factor. How is sickling precipitated? That the same reason is vaso-occlusive crisis, infarction, by infections, dehydration, rapid change in temperature, pregnancy, menses, and intake of alcohol. This can lead to vaso-occlusive crisis. And these vaso-occlusive crises, the organs affected, all of the major organs, I would say. So brain is affected, that can lead to stroke, which could be the ischemic or hemorrhagic. And then there would be vasculopathy. In eye, there would be hemorrhage or blindness. In liver, there would be infarcts. Because of there can also be hepatomegaly, but that is not because of the vaso-occlusion. Partly it is because of the vaso-occlusion, because um oh no, so not because of the vaso-occlusion, because RBCs, they are being hemolyzed, and there is intravascular hemolysis going on. And because of that, body is trying to make more and more blood, but not just from the bone marrow. Body is trying to find extramedullary hematopoiesis areas, which can include liver too. That is why liver is being increased in size. But there are infarcts, which are because of the vaso-occlusion, right upper quadrant syndrome, lung. There is acute chest syndrome, long-term pulmonary hypertension because of the vaso-occlusion. And just to avoid this long-term pulmonary hypertension, in the screening of sickle cell disease, we're going to read that we go for echocardiogram, this last point. Echocardiogram once in late childhood or early adulthood, just to screen for pulmonary hypertension. So there is some acute chest syndrome going on, because of the vaso-occlusion, in the lungs. And what happens in this one is acute illness which is characterized by fever or respiratory symptoms. So if we get a chest x-ray, we'll see there's a new pulmonary infiltrate. This is what we call as acute chest syndrome. They will have fever, and they will have respiratory symptoms, and there would be a new pulmonary infiltrate. This is precipitated by pulmonary infection, or by pulmonary infarction, or by fat embolism. Other than lungs, we have gallbladder stones. Gallbladder stone formation is because RBC is being destroyed, and there is intravascular hemolysis going on, which would lead to increase in unconjugated bilirubin. That would lead to jaundice, signs of jaundice, scleral electris, and gallbladder stones. And in heart, we'll have flow murmurs, hyperdynamic flow murmurs. In spleen, in children, it's enlarged. In adults, it's atrophic. In kidney, we can see hematuria, especially in the carriers, sickle cell carrier, which we call a sickle cell trait. Loss of renal concentrating ability, which we read as hyposteneuria and proteinuria. In intestines, if there's vaso-occlusion, that would lead to acute abdomen. In placenta, that would lead to stillbirths. In penis, that would lead to priapism, which is painful, prolonged erection. Um, in digits, as we read already, that leads to dactylitis. There's pain and inflammation in the digits because the bones are not being supplied, not being perfused. In bones, there is infarction, infection, which we can also say is osteomyelitis, avascular necrosis like femoral and humeral head. So we can have MCQs like this too, that there is pain in the femoral head or humeral head. So these tend to have more of the avascular necrosis pain prominently over here. So this can present as a scenario too, femoral and humeral head. So be careful about the bones, avascular necrosis. And then on skin, they have some leg ulcers on the ankle where it is not perfused. Sorry. So hemoglobin SC. Hemoglobin SC is the most common compound heterozygote. It happens in African Americans. It is milder anemia. It has anemia, but it is milder than hemoglobin SS, which is the monozygous. It has more or less similar complications, vaso-occlusion and pain crisis and aplastic crisis and splenic sequestration and acute chest syndrome, but they are typically milder and less frequent in hemoglobin SC because they have hemoglobin S as well as hemoglobin C, but they do not have hemoglobin A. So we're not like in very good state. Okay, over here we have some typical specific complications. We have retinopathy, proliferative sickle cell retinopathy, glomerulonephritis, and avascular necrosis. So these are the most prominent ones in hemoglobin SC disease, sickle cell disease, which is SC. So some problems with the eye, retinopathy, glomerulonephritis, and avascular necrosis. But spleen is not always atrophic in adults with SC disease. Okay. Now, how are we going to investigate for the sickle cell disease? We're going to do sickle cell prep. What it does is it detects sickling of the RBCs. Whenever we are giving some oxygen lowering agent, it detects where and how much of RBCs are being sickled. It determines the presence of HbS allele, hemoglobin S allele. Of course, if there is sickling, that means there is hemoglobin S allele. But it doesn't depend how much is hemoglobin S and how much is their hemoglobin A. And if it is homozygous hemoglobin SS or heterozygous hemoglobin AS, for that we are going to go for hemoglobin electrophoresis. And in that we distinguish hemoglobin AS, hemoglobin SS, hemoglobin SC, and other variants. And in developed countries, we typically screen for sickle cell disease in all newborns. In this table, we can see the investigations in the CBC in hemoglobin AS, which is just the trait, just the carrier. CBC is normal, but in hemoglobin SS, just to compensate, we and because of so much of RBC destruction and loss of hemoglobin, there is decreased hemoglobin and there is decreased hematocrit, and just to compensate that, for the counteract part, the reticulocyte count is increased. Bone marrow is trying to compensate it. In the peripheral blood, hemoglobin AS is pretty normal. We can also find a few target cells, but hemoglobin SS, we can find sickled cells there. And electrophoresis, hemoglobin AS would have a 60%, 65% hemoglobin and 35 or 40% hemoglobin S. But in hemoglobin SS, there is no hemoglobin A, no normal hemoglobin. It only has hemoglobin S and a little bit of hemoglobin F, which like if it's very early, a very young baby, then they might have a little more hemoglobin F. So that proportion changes with age. But they also have normal amount of hemoglobin A too, just like it was in a normal person. Okay, moving forward, how are we going to treat sickle cell disease? This was all about like sickle cell disease, their pathophysiology, what's happening in there, and how is that going to present. Now we're going to move on towards the treatment. We're going to go for genetic counseling. The hemoglobin, the AS, the ones which have the sickle cell trait, they do not need any treatment. And hemoglobin SC, they need a treatment as per hemoglobin SS, the homozygous ones, depending on the symptom severity. So how do we treat hemoglobin SS? How do we treat sickle cell, like SS is sickle cell disease, right? So we try preventing folate deficiency. That is why we give folic acid. Other than folic acid, we can give hydroxyurea. Hydroxyurea, what it does is it enhances the production of hemoglobin F. What hemoglobin F does is it tends to decrease the polymerization and precipitations of hemoglobin S. So hemoglobin S is the one which forms sickles, right? So the presence of hemoglobin F in the sickle cells, sickle cell RBCs, decreases the polymerization because it stops the repression of hemoglobin gamma chains and initiates differentiation of stem cells expressing this gene. So this is the mechanism of action, which is not important. All we need to know is that it enhances the production of hemoglobin F. This is why in this table, in the yellow part, sickle cell anemia, if the patient is on hydroxyurea, what happens is that was sickle cell anemia in the first place. So they would have no hemoglobin A, no hemoglobin C, and normal amount of +1 hemoglobin A2, but they'll have all of the hemoglobin S, just like the one mentioned in the red, right? But in this case, in the hydroxyurea, they have more hemoglobin F. So what hydroxyurea does is it tends to increase hemoglobin F. Hydroxyurea works with hemoglobin presence, enhancing the production of hemoglobin F. But hydroxyurea, on the other hand, has a lot of side effects too. We did a study too to assess the effects of hydroxyurea therapy in patients of any age and genotype with sickle cell disease. And we got to know that hydroxyurea can effectively decrease the frequency of the pain episodes and other acute complications in patients with sickle cell disease. But the long term benefits and risks of hydroxyurea is still insufficient. What kind of harms they can do? Short-term harms, if you're just giving it for 6 months, so within 6 months it could do dose-related leukopenia, thrombocytopenia, anemia, which is already our concern, and it would increase that. So anemia, leukopenia, thrombocytopenia, and it will also decrease reticulocyte count. It can also decrease sperm production, mucositis, skin ulcers. So these are the side effects of short-term usage of hydroxyurea, but long-term can lead to birth defects in the offsprings of people receiving the drug. So if a man is receiving, the people who are receiving the drug, they can have birth defects in their offsprings. And the children who are receiving this drug, they can have growth delays. So in adults, they will have problems in their babies. In children, they will have growth delays. And in children and adults both who receive this drug, they are on higher risk of cancer. So it's not that good, but we use it depending on the ratio of benefits to risks. So we started with the folic acid. We gave folic acid to prevent folate deficiency. Then we went for hydroxyurea. Now we are going to treat the vaso-occlusive crisis. For that, we are going to give the supportive care first. We're going to go, because in the crisis, they will have lots and lots of pain because of the vaso-occlusion or avascular necrosis going on. So we're going to go for analgesics like opioids. We can give oxygen. We can do hydration. And hydration, what it would do is reduce the viscosity and then reduce the polymerization, try reducing deoxygenation of hemoglobin S, just like over here in this cycle. So if we decrease the blood viscosity, then all of this would decrease and hemoglobin S would not polymerize that much. So we are going to try to give hydration to reduce viscosity and correct acidosis. What are the indications when we would need that? Okay, now we need exchange transfusion. So if you see that the sickle cell disease complications are occurring, like acute chest syndrome or aplastic crisis, hepatic or splenic sequestration or stroke, then you can go for an exchange transfusion. Or you want to prevent those complications beforehand, or you're going to go operate on them, you have to have some blood products on hand for exchange transfusion. And most important one is hemoglobin less than 50 to 60 grams per liter. If hemoglobin is decreased that much, then we're going to go for exchange transfusion. So supportive care, exchange transfusion, and we can also go for antimicrobials for suspected infection, because there can be any underlying infection going on, just like in acute chest syndrome. So we have to give antibiotics too. How can we prevent the crisis to happen? So there are many steps you can take before that. You can avoid the conditions that promote sickling. You can avoid hypoxia, acidosis, dehydration, fever. These are the things in our control. We can help ourselves not to get fever, not to get prone to infections, not to be dehydrated, and hypoxia, just like going to higher altitudes or exercising too much at a time. So hypoxia, avoid that, and acidosis too with that. So we have to avoid the conditions so that we can avoid sickling. We can also give vaccinations against the encapsulated organisms which we are susceptible to because of the asplinism. So we can give vaccination against the strep pneumoniae, Neisseria meningitis, and Haemophilus influenza type B. We can also give prophylactic penicillin in children 3 months to 5 years of age. We give prophylactic penicillin just to prevent sepsis or meningitis. We can maintain good hygiene, nutrition, and social support. Screening for complications. So what kind of complications can occur? So we can go for, these are very important for MCQs. So we can go for regular blood work. We can do CBC, reticulocytes, iron indices, BUN, LFTs, creatinine. So regular blood work. And then on annual basis, we can also go for urinalysis just to look for any glomerular nephropathy and any proteinuria. Then for stroke prevention, so the most important things, like brain stroke prevention, we are going and doing transcranial Doppler annually until they are 16 years of age. Stroke prevention annually, Doppler. And then eyes, retinopathy, just to screen for retinopathy from 8 years of age. Annually we are going to do the retinal examinations. And for kidneys, glomerulopathy or proteinuria, we are going for urinalysis every year. And for pulmonary hypertension, we are going to go for echocardiography once, right? So, kidneys, brain, eyes, and lungs, we are going for screening. Regular blood work, annual urinalysis, annual eye examinations after 8 years of age, annual transcranial Doppler just to look at any risk for strokes until 16 years of age, and then echocardiography once, even in it could happen in late childhood or early adulthood. And there are some more future therapies. We can talk about a little bit of gene therapy. There is voxelotor and crizanlizumab. These are some options which we can see in our future for treatment for sickle cell disease. This was sickle cell disease. There is an amazing video on YouTube which I would like to play the summary for this.
Gene therapy is another option being researched. Alright, as a quick recap. Sickle cell disease is an autosomal recessive genetic disease where the beta globin subunit of hemoglobin is misshapen, which causes red blood cells to sickle when deoxygenated, and this leads to their premature destruction as well as vaso-occlusion. Furthermore, multi-organ damage is the end result from ongoing sickling and hypoxic damage to the body's important organs, resulting in a shortened lifespan.
I also do have one MCQ regarding sickle cell disease. So there's a 1-year-old African American girl who was brought to the office. One more thing, we do read that the kid is 1 year old, and but they had hemoglobin S by birth. So why are those symptoms being presented so late? So this is because the hemoglobin F, babies usually have more and more of hemoglobin F at birth and less and not that much of hemoglobin A. This statistic in black is of a normal adult, but in babies there is more hemoglobin F, and it gets to subside eventually as the baby grows. So as hemoglobin F decreases, this would lead to increase in the hemoglobin S, and then the symptoms become prominent to us. Okay, so that is why it's not just present right on birth, because they have hemoglobin F to suppress the symptoms of hemoglobin S. Okay, that's normal. So, a 1 year old African American girl is brought to the office. They have their routine evaluation. She's learning how to walk and says mama and dada. She recently transitioned from breast milk to cow's milk. Review of systems negative. Both parents have sickle cell trait. So, both parents have sickle cell trait. Not that they are homozygous hemoglobin SS. They have traits, so that means there is a hemoglobin AS. But their sister has sickle cell disease. We are not sure if this little kid has it or not. Height and weight are appropriate for her age, so she's growing normally. Physical examination shows a well-appearing, well-nourished child with no abnormalities. Hemoglobin 14, hematocrit 42, MCV 88, reticulocytes 2%. Hemoglobin electrophoresis, hemoglobin A is 60% and hemoglobin S is 40%. So A is 60% and S is 40%. This is not a hemoglobin SS. This is also hemoglobin AS. She's also a carrier. She's also a hemoglobin. She also has sickle cell trait. So, which is the most common complication? We read that in sickle cell trait, the hemoglobin AS, there is more and more involvement of kidneys. So, kidney involvement, we read that there might be chances of renal medullary carcinoma, and because the sickling happens in kidneys, there are more and more chances of hematuria, right? So, all of these complications are there in hemoglobin SS. But acute chest syndrome, dactylitis, ischemic stroke, osteomyelitis, all of these are in hemoglobin SS, but they're not in hemoglobin AS. Hemoglobin AS has hematuria. It can present with a little bit of hyposthenuria, that urine is not being able to concentrate, so there's nocturia or polyuria, and then they present with the UTIs too, and they also present very rarely when there are factors, there's environment, when there is increased what you can say, like just high altitudes, or when there's precipitation of polymerization, then splenic infarction occurs. So most commonly it's hematuria, then hyposthenuria, and less commonly there may be an increased risk of UTIs, particularly during pregnancy. If they are pregnant, during that they can have UTIs, and splenic infarction is also uncommon but can occur at high altitudes. But other complications, they are present in sickle cell disease but not in sickle cell trait. So sickle cell disease might have osteomyelitis, ischemic stroke, dactylitis, and acute chest syndrome. In sickle cell trait, they lead normal healthy lives and they have painless hematuria, which is the most common complication. This was all about sickle cell disease. Thank you.